All right. Hello, everyone. Welcome back to a Rafael Medina Cardiology unknown case discussion. I'm really excited for the session today. We have two really fantastic educators from Columbia University. We have Ashkon, who will be presenting the case, and Theo, who will be the discussant of this unknown cardiology case. So without further ado, I will pass the mic to both of them to introduce themselves. If they like, they can kind of share a story of how they worked together, a story of an experience that they had together, and then we'll dive into the case. So Ashkon, I'll pass the mic to you.
Thank you so much. Thank you everyone for being here and really appreciate this opportunity to be a part of this. I would love to introduce Theo, so Dr. Kleanthis Theodoropoulos. His journey in medicine began in Greece at the University of Patras, where he graduated from medical school and earned his PhD in internal medicine with research in the association between obstructive sleep apnea and subclinical carotid atherosclerosis. He was part of the Department of Clinical Trials research team at Mount Sinai in interventional cardiology as a postdoctoral fellow, and then he got his internal medicine residency training at Sinai. After that, he did cardiology fellowship at SUNY Downstate, then interventional cardiology fellowship at Montefiore, and then got his fellowship in advanced heart failure and transplant at UCLA. He's now an attending physician and assistant professor of medicine at Columbia. And his interests include cardiogenic shock, mechanical circulatory support, remote monitoring of patients with heart failure, as well as the treatment of coronary allograft dysfunction. And he is interested in combining interventional cardiology and heart failure together to treat patients. It's been a pleasure of mine to work with Dr. Theodoropoulos in the cardiac care unit at New York Presbyterian, and he's just been such a supportive, wonderful mentor to have. And so thank you for joining us today.
Thank you, Ashkon, and good evening, everyone. It's my pleasure also to join your group, and I hope the session will be very productive and didactic for everybody. From my side, let me also introduce you Dr. Ashkon Rahbari, who is a third year currently internal medicine resident at New York Presbyterian, Columbia here in New York. He's also a California native. Ashkon graduated from the US Santa Barbara in pharmacology, and then he completed his medical degree at the Northwestern University, Feinberg School of Medicine. He has always had a deep commitment to serving his community, having volunteered at both street medicine organizations and also free clinics. His research has evolved from studying animal models of diabetes as an undergraduate to clinical research in multiple myeloma, lung cancer, and lung transplant. Currently, his research focus mirrors his clinical interest in advanced heart failure and transplantation. And this year he will be applying for the cardiology fellowship driven by his fascination with the complex physiology of the heart. On a personal note, Ashkon is a proud older brother to a younger sibling who is beginning also his medical residency at Vanderbilt. On a personal note, also Ashkon, I met him about a month ago. We did a long rotation CCU. He was able to handle very complex cases with cardiogenic shock, ECMO, impellas. He demonstrated really good level of knowledge. He was very confident, managing the. I used to say the toughest, patients in the hospital, and it was my pleasure working with him. And I'm pretty sure he will have a great, successful cardiology career.
Wow, amazing. Those are both incredible introductions. What two incredible people we have here.
Yeah.
All right. Well, I know we have a really kind of packed case, and I know we'll have kind of a lot of great discussion from it. So I think we can jump into the case now. So Ashkon, I will pass the mic to you, and feel free to share the first aliquot.
I would love to. So to begin, our case actually starts with a hospitalization that occurred outside of our institution before the patient came to us at Columbia. So we'll start with that story. So he's a 79-year-old male. He didn't really have any significant past medical history before this all started. He was working in building maintenance, and he was working on patching his ceiling at home when he fell off of a stepladder. Afterwards, he had some confusion, but then regained clarity, denied losing any consciousness. He went to the ER where he had a CT of his head that showed no acute intracranial abnormality. He had a CT of his chest that showed no acute cardiopulmonary process, and he was diagnosed with a non-displaced fracture of his right wrist. So he was sent home. Following this, though, for a couple of weeks, he started to have this unsteadiness, balance issues. He followed up with a neurologist, and he had a CT scan of his head done that showed a small subdural hematoma in the right frontal region. Initially, they didn't want to intervene on this, but then he continued to have worsening symptoms. He actually fell again. So he went to the hospital, and this time the subdural hematoma was actually larger in the frontotemporal right side of his head, with some small amount of midline shift, about 3 millimeters from right to left. So he was admitted to the neuro ICU at the outside hospital, and this was over a month from his initial presentation to the ED from his first fall. So he had this procedure, which is right middle meningeal artery embolization. And that procedure was complicated by a femoral artery occlusion that happened at the access site at the right groin. So that required endarterectomy and thrombectomy, which was successful. He also had this subdural evacuating port system, or SEPS, that was placed. 60 cc's of fluid was drained from this hematoma with improvement, and the drain was removed. So a few days after that, now 5 days into his hospital stay, he developed hypoxemia. Now, he didn't have any fever, he had no cough or phlegm, he had no other typical URI symptoms. However, he did have some exertional shortness of breath that was worse when he was standing and moving around. And he was actually placed on high flow nasal cannula. So that's the story so far. We can get into a little bit about his past medical history and other related details. So again, his past medical history wasn't really too significant. He had some high cholesterol for which he was on simvastatin 40 milligrams daily. He also was noted to have this thoracic aortic aneurysm that was diagnosed initially in 2012, but over a period of 9.5 years, it really didn't change too much. It went from 4.8 to 5.1 centimeters in size, so it was deemed relatively stable. And medications, nothing other than the simvastatin, no known drug allergies. For social history, like I said before, he was working in building maintenance up until the point of his initial fall. He's a former smoker, but quit date over 40 years ago, and just a few cigarettes daily before then. Drinks a glass of wine nightly, lives with his wife, and was previously completely independent. Family history, he has no family history of any clotting or bleeding disorders. No specified cardiovascular or respiratory disease in his family. And I should also add that he was taking no pain medications, no blood thinners, nothing like that. On his physical exam, he required high flow nasal cannula, 4 liters, 50%, with a saturation that was noted to be in the low 90s. At some point, they tried to take off the high flow overnight, but he would desaturate into the low 80s. And so he always required high flow to maintain his peripheral sats above 89%. His blood pressure was 102/60 and ranged from 100 to 140 systolic. Pulse was 61. His saturations we discussed already. His physical exam, well-developed gentleman, appropriate for his age. His cardiovascular exam was unremarkable, with normal S1, S2, normal rate and rhythm. Pulmonary exam initially had some faint crackles, but mostly throughout his hospitalization, he had a clear pulmonary exam without any respiratory distress. Nothing really significant in his abdominal exam. Was flat, soft, non-tender. Extremities, he never really was demonstrated to have peripheral edema, always had warm and well-perfused extremities throughout. Neurologically, initially when he had his symptoms before his intervention, he had some lower left extremity weakness, 4 out of 5, and some mild pronator drift in his left arm, but since then he's had a normal neuro exam. In terms of his labs, really largely unremarkable. His CBC, he had no anemia. His white count was 9. Platelets were 223. His BMP, again, similarly unremarkable. His mental status, I see a comment. His mental status was actually great throughout his hospitalization. He was alert and oriented. He never had any speech difficulties. Great question. His ABG, while on high flow, presumably the settings I talked about earlier, 40 liters, 50%, pH was 7.46, his PCO2 was 33, his PO2 was 67. His procal was only 0.07. His coags, he had an INR of 1.1. And so I'll stop there for a second just to see if there's any questions or thoughts before we move on to the imaging.
Yeah, Ashkon, thank you for sharing all of this data. And Theo, I will turn it over to you now. And, given all this data, maybe we can kind of narrow in on the hypoxemia that Ashkon told us about. And if you could talk a little bit about how you approach hypoxemia in general, how you would think about the causes in this case in particular.
Right, yeah. One thing I would like to mention before that, when you see a case like this, when they say 79, especially a little patient fell off the step ladder, always think about any syncope, right? I'm not saying it's related to the case, but I just when you get your history, always ask it's a fall or mechanical fall, or is someone lost in consciousness, because that opens especially when someone says no past medical history. But considering now that the guy he just fell down, now the hypoxia, right? The hypoxia in my mind is like either a VQ kind of VQ mismatch, right? Perfusion ventilation mismatch, which could be infectious reasons like pneumonia, for example, right? It could be perfusion mismatch, which could be like an acute PE, and given the situation here, the patient was for a long period of time in the hospital, increases the risk, for thrombotic events, right? Is more inflammatory, status. Other cause of hypoxia, obviously, other lung diseases, like interstitial lung diseases. However, in his case, it's kind of uncommon because the guy, he was feeling fine before coming to the hospital. So interstitial lung disease is less likely. Other causes, obviously, cardiac etiologies, right? Pulmonary edema. Another, actually, in the differential diagnosis, I will also put like a hemoglobin, like a disorders where there's no like a less oxygen, binding capacity, especially, when you see, mold in the houses or, in the fire environments and stuff like that. I think that also could be, but it doesn't add to the history here. So because it's more like an acute process. So when I see this acute process, I think, in my opinion, it's either, infectious or something related, maybe PE or cardiac-wise. Now, cardiac-wise, when I say like a heart failure or pulmonary edema or like kind of shunting, right to left, left to right, shunting or stuff like that. It's not so common just to be, it's like so acute, right? It could be in the setting of like someone has like a congenital heart disease, so you have some symptoms, or you can have a shunting in the setting of like an MI, which doesn't seem like also is the case here. So, based on the physical exam, he said he has some crackles at the basis, which could be either a fluid, could be pneumonia. But on the other hand, from the lab workup, right, like the white blood cell count is normal, so infection and the procalcitonin is it's kind of low. So infection also doesn't look very likely. So I think we'll need more. Information. But from the first, review of the data, that's what I would do. I would narrow down my differential diagnosis. And then also, Ashkon, I'm not sure if you know that, it will be interesting to know if this guy, I'm pretty sure because of the intracranial, bleeding he has, the guy probably he wasn't taking an anticoagulation. So, that increased the risk of some thrombotic complications, like such as acute PE or DVT. So that's what I would think. Now, the thoracic aortic aneurysm, it's interesting too. When I see thoracic aortic aneurysm, either some, but obviously it's kind of like a moderate to large size, right? It's like a 4.8 to 5. You start to think that this guy probably, he does have some past medical history, maybe hypertension, or he has some, connective tissue disorder, which sometimes can be, and he was just undiagnosed. That this would be, broadly my differential here.
Well, thank you so much for that very broad differential in that discussion, and your inclination was exactly correct in this case. And to reinforce and answer some of the questions that you all had in the chat here, so this was a long hospital stay. He did have these procedures that occurred just days before, 2-3 days before this event, this hypoxemia, that occurred on hospital day 5. So to get into the imaging, his chest x-ray was clear. He had a CT angiogram that showed subsegmental pulmonary emboli within the lingular and the right lower lobe pulmonary arteries. The lungs were otherwise clear. It did demonstrate this ascending thoracic aortic aneurysm that was 5.2 centimeters in size. Other than that, there was abnormally increased thickness of the walls of the left ventricle, which was suspicious for left ventricular hypertrophy and inward deviation of the interventricular septum into the left ventricle, with relatively larger caliber of the right ventricle, so they could not exclude RV strain. However, there was a transthoracic echocardiogram that was done showing an EF of 53%, only stage 1 diastolic dysfunction, which said it may be normal for the patient's age, no AV aortic valve stenosis with a tricuspid aortic valve. Otherwise, the pulmonary artery systolic pressure was estimated to be normal. There was also some aortic root dilation at 5 centimeters. So ultimately, the patient was diagnosed with subsegmental pulmonary embolism, was started on a heparin drip that was then transitioned to apixaban. However, despite over 10 days of therapy with anticoagulation, the patient's hypoxemia failed to improve. And it also seemed that the patient's hypoxemia did not seem to change despite titration of the high flow nasal cannula. So we'll stop there. So what thoughts do you have now about this case?
Yeah, so first of all, it's good that you gave us, the CAT scan findings, but, for all of us, it's always good to, before you jump for a CAT scan, always do a risk stratification of these patients, and maybe just a simple test like a D-dimer sometimes can be, when you, not in this case, but in general, I want to just to mention that if someone is like a low risk patient, for PE, based on the clinical history, like it's not tachycardic, no EKG changes, no hypoxic, no, lower extremity DVT, swelling or, pain, calf tenderness and stuff like that, then it's just in low risk patients, just the D-dimer. If it's negative, you don't need to do a CAT scan, right? Now, in this case though, because the guy also has persistent hypoxia, and this seems like it's a high risk because we said maybe not on anticoagulation and stuff like that. So we did a CTA. So the subsegmental PE usually, of course you can have hypoxia, but seems like it's disproportionate to the level of the extension of the PE is disproportionate to the amount of the hypoxia and the patient's, symptoms. Usually, I would Ashkon, can I see a little bit? The echo. What did it show exactly besides the EF? Did it show any right side strain or not?
So the echo did not. So what it showed, it didn't have a great view of the right ventricle. However, it estimated that the pulmonary artery systolic pressure was normal based on the tricuspid regurgitant jet that it saw, only trace tricuspid regurg. It also estimated a right atrial pressure between 10 to 15 millimeters of mercury based on an IVC that was a little bit dilated and collapsed less than 50% with inspiration.
Right. So it's not like a massive or submassive P, at least based on what we see here, based on the echo. I mean, I don't know the pro-BNP. The pro-BNP was normal and the troponin?
So we didn't have it from the outside hospital.
Oh, I see. Yeah.
At our hospital.
Okay, that's fine. Yeah. Another thing I want to mention about the subsegmental PEs, they are more prone to cause, more inflammation and cause like a kind of infarct, like a lung infarct. So that also could play a role, but again, the infarct per se, in my opinion, it wouldn't explain, all this, hypoxia. So I'm wondering if there is anything else, that like any pulmonary hypertension that the patient had that could cause that. I'm not sure. I mean, just from the PE, I'm not sure if it's that can answer all the questions like patient symptoms. Any evidence of pulmonary hypertension on no, right, on the echo? The
No,
PA systolic pressures are fine, right?
yeah, correct.
Yeah.
So the next step that they took at this hospital was to do a limited transthoracic echocardiogram with bubble study.
Okay.
So on this echocardiogram, it was limited. It noted normal LV systolic function, trace aortic insufficiency, and it noted a couple interesting things. So one was it said that the bubble study was consistent with PFO, and they also found an interatrial septal aneurysm. Unfortunately, they don't go into, from the outside hospital records, they don't characterize more about it, but those were the findings. So what was interesting is shortly after getting this study, the patient experienced a transient episode of left-sided weakness and confusion that lasted about 10 minutes. So after that, a CT head was done that didn't show any change in the subdural hematoma. The neurology team was actually consulted, and they felt that it was less likely that this was due to the PFO itself and more likely to be something like a seizure event in the setting of his known subdural hematoma with some post-ictal confusion and left-sided weakness that then resolved. However, an EEG was done for over 24 hours that had no epileptiform discharges. So I think this makes us think about, first of all, what do you think is the significance of the findings on this bubble study, and how are you thinking about the PFO in this patient?
Yeah, I mean, the PFO definitely, it can cause like embolic phenomenon, like, as we know, it can be associated with strokes, right? Especially in the setting of a DVT or PE, right? If someone has that candidata, so it definitely increases the risk of stroke. And I think it was a good choice that they did some workup, for the stroke at that time when the patient had these symptoms. But the PFO per se, I wouldn't say that, in my opinion, that can potentially, explain all this, like the, patient's, hypoxia. Unless someone has like a more, I would say, like a ASD, like a bigger, shunting. But when you say, but when someone says that, that you see PFO with the bubble studies, and you don't have any other reasons, I would do further workup, to look for, to see if there's any ASD. Probably I would do like a TE. Yeah, because the shunting, in order to have, like just to the, let's say the shunting to cause this hypoxia, you need to have a good, like a left to right. Right to left, right? In order to have like a right to left, you need to have elevated, PA pressures, to have a reversal, flow. And I don't think the PFO, can cause that. You can have like enough. So did they do any further like a TE on this patient?
So that's where our story kind of brings the patient actually to Columbia. So after this event, this complication that happened after the bubble study, as well as the patient's persistent hypoxemia that has gone on now for weeks at this outside hospital, the patient and the family elected to leave the other hospital and come to Columbia for further workup. And so we'll continue the story from there. When he arrived to our hospital, he was actually saturating 95% on 4 liters nasal cannula. His exam was similar. He continued to be alert and oriented. He had clear lungs. There were no murmurs that were auscultated. He had a regular rate and rhythm. Telemetry didn't really show any abnormalities either. His laboratory findings, so he had that pro-BNP that we were talking about earlier was normal at 116. An RPP was negative. A procalcitonin was normal. And again, he had an ABG that was similarly described a large AA gradient with a PaO2 of 56 while the patient was on those high flow settings at 40 liters, 60%. So he actually had a CT scan that was repeated, a CT angiogram, when he arrived to Columbia. And at this point, there was some degradation due to motion, respiratory motion artifact. However, there were no filling defects that suggested any pulmonary embolus. So it failed to redemonstrate those PEs. It similarly showed this ectasia of the thoracic aorta, this time only 4.8 centimeters. It did show this peculiar finding of reflux of intravenous contrast into the IVC, which the radiologist read as suggestive of right heart dysfunction. A TTE was repeated here, and again, it demonstrated this interatrial septal aneurysm. It describes it as this hypermobile, redundant tissue in the region of the fossa ovalis that's consistent with that diagnosis. Otherwise, couldn't really see the RV too well, but didn't remark on any signs of elevated RV dysfunction. It also was unable to assess for pulmonary artery systolic pressure due to the lack of a tricuspid regurgitant jet. So due to everything that was the patient's history, when the patient arrived at Columbia, he was placed on a heparin drip for anticoagulation in the setting of his recent PEs, with a recommendation by neurology to monitor for stability. He was initially admitted to the floor actually because his saturations were okay on nasal cannula. However, overnight he was desaturating into the 80s, and so he was actually triaged to move from the floor to intermediate care to the step-down unit, so he could have continuous cardiorespiratory monitoring as well as high-flow nasal cannula. So at this point, I think this begs a few different questions. So, first of all, this persistent hypoxemia, despite the resolution of the PEs, or at least the absence of them radiographically, how are you thinking about that in this patient? And how would you think about something like pulmonary hypertension in this patient, given the findings, the lack of findings we have on the TTE, but this finding we have on the CT scan of reflux of intravenous contrast into the IVC? I think you're muted.
Yeah, sorry, yes. Yeah, the pulmonary hypertension, should be in the differential diagnosis because, although there is the notion that the larger the PEs, the higher likelihood, for pulmonary hypertension, but I don't see that necessarily. I have seen, like patients that develop pulmonary hypertension even with a smaller type of a PE. So, and the CAT scan, as you know, the CT scans, they're not necessarily, diagnostic for that. So if we're thinking like a chronic thromboembolic pulmonary hypertension, like a CTEPH, a VQ VQ study, to see like a mismatch might be better. So and I think that should be part of the differential diagnosis. And obviously, if you want to be more accurate, then maybe a right heart cath, it will give you valuable information because, first of all, you measure the pressures, but more importantly, here also we'll see the saturation to see if there's any step up or step down, the saturation that can explain, the hypoxia, especially if there is a suspicion for maybe ASD or PFO. But also, as we discussed, maybe also some lung workup as well, right? I saw some of the notes, some of the messages, to do like a DLCO to see if there's any interstitial lung disease. The CAT scans, they were high resolution CT scans or like for interstitial lung disease or just, yeah?
Well, they were CT scans with contrast, so they weren't the absolute best studies, but they were high resolution studies that really didn't demonstrate any significant parenchymal change.
By the way, sorry, I didn't ask you, did he have a DVT, this patient?
So both at the outside hospital and here at Columbia, the ultrasounds of the legs did not demonstrate any deep venous thrombosis.
No venous thrombosis, I see. Okay. Yeah, I mean, I think, a right heart cath would make sense, in my opinion, here to measure, and a VQ scan to rule out, to see if there's any mismatch for CTEF would also be reasonable.
And Theo, before we move forward, Ashkon has given us such kind of a rich history of both what happened at the prior hospital and this hospital. And before we kind of move to the next aliquot, I'm wondering if you could kind of summarize how you are framing the patient in your mind right now.
Yeah, right now we have like a 79-year-old male with no past medical history who had a fall. And then he hit his head. He developed, I believe, it was subdural hematoma. He had some neurologic interventions during that hospitalization, prolonged hospitalization, probably. He didn't get any anticoagulation. Then he developed, subsegmental PE with some persistent, hypoxia. The echo, or at least so far, doesn't show any significant RV strain, or I'd say, RV strain, but it does show some PFO and some interatrial, septal aneurysm. But other than that, all the labs so far, they have been unremarkable. Besides the, the very low PO2, like the persistent, hypoxia. So, and then there's my understanding there's no suspicion for pneumonia or, interstitial lung disease. So literally here, one of the thoughts will be like a pulmonary hypertension, pulmonary hypertension secondary to, the CTEF. How long was it ago now, Ashkon? Like how many days has been since the event? Like at the initial insult?
So the initial insult happened approximately 2 months before the patient was admitted to Columbia.
Right.
In terms of the PEs, we're now looking at basically a 2-week period, just over a 2-week period from the diagnosis of the pulmonary embolism.
Right. The heart otherwise doesn't seem like there's any kind of cardiomyopathy, suggestion of cardiomyopathy, thickness, or I'm not sure if it has any, like a HFpEF kind of physiology. I'm not sure. Do you know anything about that?
Sure. So a few points on that. So one, they did show at the outside hospital that the patient had grade 1 diastolic dysfunction, but this was deemed kind of consistent with the patient's age and not necessarily pathological. The patient did have some note of some maybe mildly increased thickness of the left ventricular wall consistent with LVH. However, in terms of congestive symptoms, signs of peripheral edema, elevated BNP, the need for diuretic, he didn't have any of those things at all, and his left ventricular EF was normal on every one of these studies.
Right.
So I think that brings us to this point in the case where there's a conundrum here and the consultants get involved. So pulmonology and cardiology are involved in this case. And the thinking at this point is that, this patient has probably had this, has had a PFO his whole life. But now in the setting of these pulmonary embolisms that he then had an increase in pulmonary artery pressure, which then led to a transmission of increased right atrial pressure and potentially more shunting through that PFO, which is, responsible for his hypoxemia. So one strategy that the team thought to do and the consultants wanted to do was actually empirically start the patient on sildenafil, despite the fact that there wasn't really evidence at this point that the patient did have pulmonary hypertension. So that test that you did want, Theo, was performed, which was a right heart catheterization, which I would love to get your interpretation on. So
before that, sorry, I'm not sure if the empiric initiation of sildenafil is the rightest thing to do in general, because when you give these medications, you need always to have in your mind that you can cause, more VQ mismatch, right? So for example, if someone has like pulmonary hypertension secondary to interstitial lung disease, right? You increase the perfusion through the sildenafil, but the patient doesn't, there's no good exchange of the oxygen. So, sometimes you can have the opposite results. And then also you don't know exactly what's the wedge, right? Because if you have a wedge pressure of like a 30 and you give, sildenafil, you're going to make, you're going to make, patients, more prone to, to develop, pulmonary edema. But I guess, the echo he had, it was like a kind of reassuring. So they didn't think that the patient was like, he has, as we discussed, severe diastolic dysfunction and stuff like that. Okay, let's see now the right heart cath numbers.
That's a great point about worsening VQ mismatch when you give these medications like sildenafil. So the right heart cath, the right atrial pressure was 2, the right ventricle had was 22/1. The pulmonary artery pressures were 21/3 with a mean pulmonary artery pressure of 11. The pulmonary capillary wedge pressure, or the wedge, was recorded at 0, and the left atrial pressure was recorded at 3. Now, interesting actually that they reported the left atrial pressure specifically. PVR was only 2. The cardiac output was 3.8 by FIC with an index of 2.33. And then there were oxygen saturations that were also obtained at different points during the procedure. So one is on an ABG, just peripherally. There was oxygen saturation actually of 100%. In the superior vena cava, there was an oxygen saturation of 68%. In the right atrium, it was 65%. In the pulmonary artery, it was 66%. In the left atrium, it was 95%. So following the results of the cath, sildenafil was actually discontinued. So how are you thinking about what they did on this cath and what these pressures and what these oxygenation values tell you about this patient?
I mean, pretty much here, the feeling pressure seems like they're low normal, like normal or very low. Right atrial pressure of 2, mean PA of 11, the wedge 0 to 3, something like that, right? And the cardiac index was like a 2.3. Like not impressive. Sometimes, you can have low PA pressures, especially in the setting of a PE, and that always you need to suspect, kind of RV dysfunction, right? Just the RV is not like strong enough to generate pressure, but but that you'll see though in the setting of elevated, RA pressure, like if you're suspecting about RV dysfunction, I'm talking about, right? So it doesn't seem like any of those things. It's like kind of normal, like right heart cath numbers. And then the other thing here is that also there's no step up, right? SVC 68, right atrial pressure, right atrial saturation 65, and the PA 66. So it's not significant. Usually, in order to be significant, you need to see like a increase on the saturation by 5 to 8%, right? To say that there is some maybe suspicion of shunting. So yeah, interesting. It's getting more and more interesting in this case. So sometimes also, regardless of this patient, I just kind of, if you see someone with dyspnea, right, and someone is in the hospital with dyspnea, not necessarily hypoxia, but the patient is developing this complaining of dyspnea on exertion, and you do right heart cath and you see these numbers, the next thing I would do for him, I would exercise him on the right heart cath. I want to see how his feeling pressures behave like when the patient is on exertion, because sometimes you have what we say exercise-induced pulmonary hypertension. But again, this guy now we're talking about someone who's like a persistently hypoxic, it doesn't fit that category. I'm just saying in general though. Not sure. Yeah, I mean, it doesn't seem like he has a pulmonary hypertension, right? I mean, PA is normal. I'd like to, that can explain the hypoxia. And also that's at least suggests if there is no significant, there is no shunting.
So another question I have for you, Theo, is, how feasible is it during these studies to actually pass the cath on a right heart cath into the left atrium to get these values. And when you do something like this, are you able to characterize the intracardiac shunt in any way?
No, but yeah, sorry, that's a good question, but I didn't realize that. Why do you say that the left atrium it was like a 95? How did they cross it?
So the interventionalist actually was able to pass the cath into the left atrium in the cath lab during
Through
the
the
right
PFO, maybe? Or no? Oh, I see. Yeah, usually, we don't do it. It's not something super common, and and if you always, if you are always interested to find about, left atrial pressure, sometimes also you can get the wedge, saturation. Personally, I haven't done it, so like to cross, the PF4 or ASD to get it. So I cannot comment on that, how easy it is. I mean, it does require, of course, experience. And I guess someone experienced that, cross the septum, like interventionists who are doing some, mitral valve interventions that they need to cross, the septum.
All right, so the next bit of history that we can talk about. So the sildenafil, like I mentioned, was discontinued. Unfortunately,
sorry, Ashkon, this is all on sildenafil, these numbers?
Correct.
I see.
Correct. The sildenafil, however, was discontinued after the results of this right heart cath were obtained. After this, the patient actually had that CT scan for stability. And unfortunately, there was some interval increase in size of the subdural hematoma slightly in the absence of any clinical change. So the patient's heparin drip was discontinued and the patient was closely monitored. Fortunately, after that, CT scans continued to show stability. So the patient continued to require high-flow nasal cannula for persistent hypoxia. And the next step that some of the consultants wanted was to actually repeat a bubble study or potentially get a TEE as well to better characterize this PFO, especially in the setting of these right heart cath numbers that were largely unimpressive for any significant right to left shunting. However, the patient and the family were reluctant to do this based on the complication that they experienced before. One very, very interesting thing that we can now add to the physical exam component, which I actually saw somebody comment on very astutely to ask this question. So pulmonology was at the bedside. And what they did was they did a maneuver where they showed that while the patient was lying flat in the bed, his oxygen saturation was 95%. But when the patient was sat upright, the oxygen saturation dipped for between 88 to 90%. And very dramatically, the pulmonologist actually took the high-flow nasal cannula entirely off the patient and showed that the oxygen saturation was not changing at all. Otherwise, the patient continued to have some shortness of breath while standing that precluded him from working further with physical therapy, but otherwise didn't really have any physical symptoms of respiratory distress or cough or anything like that. So I guess our question here is, what do these physical exam findings to you represent? How are you now thinking about this patient? And what other studies would you get, especially in the setting of the right heart cath values that we have and the previous bubble study that we have?
Yeah, I mean, this is like a orthodeoxia, right? A platypnea kind of physical exam. And in my opinion, it seems like some intrapulmonary actually shunting that, because it changes when you change, position and you have better perfusion when you lay down and when you stand up, the saturation goes down. And yeah, as they say here, there could be hepatopulmonary. That's why I mentioned before, if the guy has like any evidence of a liver cirrhosis, something that can cause, hepatopulmonary, shunting, like pulmonary hypertension or shunting, with, because it can cause the AV malformations, and sometimes you can embolize those things. To be honest, I'm not sure if there is any specific CAT scan, like a protocol that you can do about it, or if there's any ultrasound. But before that, do you have any issues of any signs of liver dysfunction for this guy?
So you're exactly right in thinking about what were the next things that were considered. There were no signs of liver dysfunction. So he had no abdominal swelling, no signs of ascites clinically. His LFTs were all normal. He had no other markers of synthetic liver dysfunction, no coagulopathy, nothing like that. So the next steps that were taken were some imaging to kind of look at these other possible causes of shunting, these extracardiac shunts, as you talked about. So intrapulmonary shunt, looking for an AVM, and also looking for any signs of cirrhosis. So right upper quadrant ultrasound, was performed, which showed no evidence of cirrhosis, just normal appearing liver. The CT scan, so remember, he's had these CT angiograms before, but the previous one was degraded by motion artifacts, so they thought maybe if we protocolize it correctly and get a better quality study, we might find something. Despite that, a repeated CT scan protocolized for AVMs failed to find any. So now really at this point, we're left with a case where this patient has this platypnea orthodeoxia that you mentioned, which kind of makes us think about shunting. But we've really ruled out extracardiac causes of shunt, and we've considered them. So now kind of the one remaining variable here that we have is this PFO. So how are you thinking about the PFO in this case, especially now that we've kind of ruled out these other causes, and how are you thinking of, and how would you explain how shunting actually would cause platypnea and orthodeoxia?
I mean, I'm not very familiar if the PFO can explain this platypnea and orthodeoxia, especially that we see that the filling pressures, the PA pressures, they're all normal, and even the wedge pressure is low, and the mean PA. So that I'm not sure, unless if there's any other type of like anomalous pulmonary veins, return, if there's somewhere, in a different level, shunting. But my opinion, maybe I'm wrong, but I don't see the PFO to be related with a platypnea. Now, sometimes what you can do is that what you can do is that you can repeat the right heart cath with opening and closing, like a type, temporarily, the PFO or ASD, if there's an ASD, and see, how that changes, and see, if that, changes, saturations. And then also I'm feeling that maybe it's a part of these numbers we see on the right heart cath, which is kind of normal, might be a little bit because also it's on the guys on sildenafil, and might have impacted, the measurements. So, yeah, I'm not sure. Maybe I would probably repeat another right heart cath now he's off sildenafil, and maybe, to be honest, maybe I could repeat the right heart cath with a change in position. Patient on the lab, laid down and sitting up, and see how that affects, the saturations and the pressures. What did you do?
So very similar vein to what you described, but instead of looking at repeating a right heart cath, what they actually did was they wanted to see if on a bubble study, having the patient sitting upright versus lying flat would change the basically amount of bubbles that would be seen to be crossing the shunt. And so it was a long conversation. The family deliberated. Eventually, they agreed to have this done. And it was technically limited, so it was unable, unfortunately, to really demonstrate a meaningful difference between those positions. However, it did redemonstrate that there was crossing of bubbles within 3 cardiac cycles, pretty much immediately from the right side to the left atrium. So actually, what happened in this case afterwards was that interventional cardiology actually did place a PFO closure device percutaneously. And after this procedure, the patient's hypoxia entirely resolved. A post-procedure transthoracic echocardiogram demonstrated a well-seated device, and there were no complications. And the patient actually was able to be discharged on room air, and specifically there was an interdisciplinary conversation regarding antiplatelet therapy between interventional cardiology and neurosurgery. And eventually they decided that aspirin monotherapy would be okay. The patient was started on aspirin and had a CT scan that showed stability. And so he was cleared by all the consultants to be able to go home. Since then, he's had outpatient follow-ups with both cardiology and neurology without really any issues since. So before we get into kind of the summary statement, some of the teaching points that I was able to identify, I would just like to get what is your impression of this case?
I think, I think this case is that, it's more of like exclusion diagnosis, meaning that, okay, we all identify this PFO from the beginning, but, it's hard to initially believe that the PFO can cause all this, especially significant, hypoxia. But in the end of the day, there is nothing else that could explain, patient, symptoms. And that's why I'm saying that, sometimes another, in my opinion, teaching point here, when you do like one of the tests, the right heart cath or a bubble study, sometimes you need to repeat it, in a different setting though, right? It may be of either off sildenafil or a different, like a lay down, a sitting up, or bubble study with a different, body position. That always have in your mind. If the first test is doesn't give you the right answer, that sometimes you need to repeat the same test, but on a different, setting. And here, in my opinion, to be honest, as we discussed, I wouldn't think from the beginning that the PFO could explain all these symptoms. But in the end of the day, you didn't have anything else. You did a very extensive workup, and you didn't have anything else that can explain patient symptoms. So that's why I said, sometimes when you're there and you can cross it and you can close it, you can also measure the pressures and see how patients, symptoms improve or not. And if they improve, then it's an answer for you to just to put a PFO closure. But that's a very rare case. I mean, I haven't seen case like this, to be honest, but and also, the PFO, besides the hypoxia, that this guy is also high risk for the strokes, right? And so that was another reason to close it, right? Especially if you have a patient with what we call cryptogenic stroke, right? The patient doesn't have any risk factors and present with a stroke, and then you find a PFO. That's nowadays is one of the indications to close it. That's. How about what are your teaching points in this case?
Sure. So, I think to summarize the case, he's a 79-year-old man with this history of this thoracic aortic aneurysm that's been stable, who developed acute hypoxemic respiratory failure requiring high flow following complicated admission for a subdural hematoma. And he was found to have a PE on CT angiogram, however, had persistent hypoxemia despite extended treatment for this PE, and had normal right atrial pressure on right heart cath without any significant evidence of right to left shunting. He was eventually diagnosed with platypnea orthodeoxia syndrome secondary to intracardiac shunt with resolution of hypoxia after percutaneous PFO closure. So I think there's a few teaching points here. It's a very interesting case, and I think it's definitely not straightforward, and it had me puzzled for a while. But there's some interesting literature out there. There's a really nice review of this, condition by Agrawal et al. And I think we can probably share that source, as well as a really similar case actually in the European Journal of Cardiology, where a patient similarly had surgical intervention for subdural, then developed bilateral basilar pneumonias, and then after that actually had persistent hypoxemia despite resolution of the pneumonias, and actually that resolved with PFO closure. So the teaching points here are, be suspicious for PFO and other shunt pathologies in patients with persistent unexplained hypoxemia, especially in the absence of other respiratory symptoms or other signs of infection. Platypnea orthodeoxyose syndrome is a condition that's diagnosed when you have greater than 4 millimeters of mercury difference in the PaO2 between the recumbent and upright positions, or greater than 5% difference in oxygen saturation between those positions. The most common cause of this is actually intracardiac shunts like PFO, but other intracardiac and extracardiac shunts can cause it, as well as rarely just cases of VQ mismatch that make it so, there's more, basically you have worse ventilation when you're sitting upright. And then this syndrome typically, it's often incited by some preceding event that can worsen VQ mismatch and some event that can potentially increase right atrial pressure, which will cause right to left shunting. However, even in the absence of elevated right atrial pressure, right to left shunting can occur, especially with other anatomic abnormalities like an aortic root dilation or aneurysm and an interatrial septal aneurysm. So what's fascinating is in this case, it wasn't remarked on by any of the consultants, but if you dig through the literature, these other abnormalities like an aortic root dilation can actually press on the right atrium and alter the geometry of the chamber that can cause the atrial septum to get closer and the defect to get closer to the IVC, which can actually increase blood flow straight through the IVC through the shunt and cause increased right to left shunting. Same with the interatrial septal aneurysm, which can actually cause floppiness of the septum and actually, again, bring the defect closer to the IVC and increase shunting. So it's basically important to consider, even in the absence of right atrial pressure, that this can happen. And then lastly, normally the paradigm is that the more invasive the test, the more accurate info we get. But in this case, the right heart cath, which was very invasive, that information that we got was less reliable. And what was more reliable was actually the information we gleaned from the bedside and just looking at the patient and doing the simplest exam maneuver. So I thought that's what really made this case fascinating.
Yeah, wow, Ashkon, that was really what a remarkable case, and really love kind of the clarity, the teaching points that you just gave. Theo, would love to turn it over to you before we end the session if there were a few learning points you wanted to highlight and any reflections on what it was like to discuss this roller coaster of a case.
No, I mean, always, when you have a cases, you go first with the most likely scenarios or things that are more, popular. Let's say, PE, pulmonary hypertension, especially in the beginning, right? So you do all this workup instead of just chasing the most uncommon, which is a PFO, or, so you start from that, I would say the most, common causes. And then as you rule things out, then you need to go to the more, rare cases. So that's why, you saw me initially, I was just highlighting, more, like a standard of care, tests, right heart cath, echoes, bubble studies, CAT scans, make sure they, and then when you rule out everything, then makes you think that maybe that, not maybe, that's the right diagnosis. So what I'm trying to say, go from the outside to inside, like the most common to the most, to the most rare. And the physical exam is very important. The platypnea orthodoxia, sign was the key here, because it does, suggest kind of maybe it could be the PFO actually, or kind of intracardiac, something can cause this, physiology. So yeah, I mean, it was an incredible case. It was really nice and really very, perplexing for all the consultants. I'm pretty sure, the pulmonologists and the cardiologists, I'm pretty sure they had a hard time, right? Yeah, that's very nice.
Well, thank you both so much for an hour just filled with so much learning and a really interesting case. We will end the session here, but just want to thank you all so much, and huge shout out to Mario, the scribe. I don't know how you got all of that there, but so much, so grateful to you. And Mariana, really love the teaching points that you put on the board. We won't, because we're past time, we won't do it out loud, but thank you both so much. And yeah, we'll end the session there. Have a great night, everyone.
Have a good
Thank you
night.
so much.
Bye.